Smiley, lay member.
Gareth Hull, GP board member.
Well done, Rob. David Knowles, vice chair and lay member.
Phil Moore, GP and deputy chair.
Neil Ferrelly, local director of finance.
Tony Michaelides, managing director.
Great, thank you. Welcome to everyone. Have we got any declarations of interest that are not already declared, particularly pertaining to items on the agenda? No? Yes, sorry, Phil?
I have declared it in the past, but my practice provides the medical cover for the beds which are on the discussion for today.
Thank you, Phil. If we can come to the minutes of the 43rd meeting. So as regards matters of accuracy, I'm not going to go page by page, but are people happy with it being an accurate record? Yeah? Okay, so if we can just sign that off as an accurate record. And as regards the actions coming from the minutes, I think there was one action on 1.4 for Iona to get and provide a response. Has that happened?
Sorry, I beg your pardon. Is this to do with the send? Yes, I have managed to get the minutes will be shared with Healthwatch.
And I think one of the queries as to whether they would be publicly available.
So I apologise, I only asked about Healthwatch seeing them, and that was fine. So, yeah, I didn't ask about publicly available. We don't normally put internal board meetings on publicly.
No. So thanks for doing that, Iona. They haven't actually arrived as yet, so I await those with interest.
We've only had 2 meetings, and we have to wait for them to be approved at the second one, so there should be one ready to share with you. I will follow up again, but yeah, we have got it all signed off.
Okay, thank you. And the next one was around Fergus being able to liaise with the Quality Governance Committee Chair and progress the matter around the children's services.
So I can confirm I've met with Pete Smith outside of our last meeting, but haven't had the opportunity to catch up with Phil since then. But I'm happy to say it's on track, and I wouldn't keep it on the agenda. We'll just sort that out through the IQGC if that's permissible.
That'd be great, thank you. So if we can close that down. So if we can come to any questions from members of the public pertaining to items on the agenda. No. All right, so if we just go through number 1.6, items taken in private on the 7th of May. There were 4 items: the relocation of Cedars unit to PCSS site, the development of Cambridge Road Estate, which is the Hawks Road Clinic, Send Partnership Board Memorandum of Understanding, and the development of local partnership approach. Is that okay? So if we can come to, I'll just give you a very brief update on the Chair's report. So a few elements. I think nationally, we'd recently gone to the NHS Confed up in Manchester. I think one of the highlights of the Confed was a very prominent speech from David Williams from Harvard University around health, race and inequalities, which actually created a few outputs that we were going to take on board as South West London. At a South West London level, we have been meeting with the Collaborative Leadership Group, which are the local authority chairs of the Health and Wellbeing Boards, talking about moving forward together, which I know is on the agenda going forward. There was some mop-up around the clinical conference. So after the clinical conference, we've actually been getting together to actually come through to the outputs, and we're going to create working groups going forward on the outputs from the clinical conference. And at South West London as well, part of the clinical senate we've suggested that we start introducing QI methodology into assessing areas of clinical need to improve services for patients. At a local level, we've been talking about moving forward together with the council of members and also with the LMC. And we've also been looking at planned care transformation, working closely with Kingston Hospital, our local partners, as well as at South West London level to take things forward. We've also had a Health and Wellbeing Board workshop looking at the health and care plans, and also, again, talking about moving forward together. So that was a very brief update from my perspective. Sarah, I didn't know whether you wanted to add something.
So I just have a brief item, which is that the long-term plan for the NHS has now been published. And I'm sure everyone here has read all 44 pages. It's actually quite dense. There's a lot of information in there that we have to produce for our plan for South West London. The plan will be in draft form at the end of September, which we will then need to submit to the regulators, and we will receive feedback, and we will have a finalised plan by November, which will then be published. So that's the process that we are using, and I think it was today we received a whole load of templates as well around workforce and finance to fill in. So there's a lot of work to be done over the next couple of months to make sure that we build that up for South West London. We will be using our existing work, and the message that we have been giving is the same. We will use our local health and care plans and the work that we're already doing across South West London through things like the Clinical Senate to feed into the long-term plan. So we will hopefully be able to bring back to governing body something in draft in September to be able to sign off prior to submission in draft form.
Great, thank you, Sarah. Any comments or questions on either of our reports? No? Tonya, do you want to give your Managing Director's report?
Thank you, Chair. So a few things to note for members this time. The Alzheimer's Society, I'm very pleased to say, will be providing support services for those with a diagnosis of dementia and their carers on behalf of the CCG and Kingston Council from the 1st of August this year. And this new service will build on the work already underway to create a dementia-friendly community in the borough, which is part of the implementation of the Kingston's Dementia Strategy in 2015 to 2020. So it's really good news the Alzheimer's Society has been able to supply that service for us. So I'm very pleased to see that. On the 22nd of May 2019, I hosted the first South West London personalised care workshop, which had 65 people in attendance, and launched the South West London Personalised Care Network, or Collaborative. And it had representation from South West London CCGs, local authorities, service users, voluntary sector organisations and local authorities. And members will know that personalisation is a large part of the long-term plan. So we really welcome that priority given in the long-term plan for this agenda. And I'm really looking forward to working with those people who are championing personalised care across South West London as we move forward. During June, we had mental health training workshop for line managers, and the session aimed to help participants support their team members with managing their mental health at work. Members will remember that we signed as a CCG the Time to Change initiative, which is helping to raise awareness about mental health issues in the workplace. So that training really supports our commitment to Time for Change. Vicky can't be here today, unfortunately, because she's in Balearic Island somewhere. But I'm very pleased to say that Vicky Harvey-Piper, who is our Director of Corporate Affairs and Governance, has been nominated by Sir Vince Cable for a parliamentary award for the work she has led to improve the wellbeing of staff at NHS Kingston and Richmond CCGs. Following deliberations by a regional panel of experts who considered almost 600 nominations, Vicky was chosen as a London regional winner for the Wellbeing at Work Award. So our congratulations to Vicky. She's going up next week, and she really would want me to say that was a real team effort. So those she's been nominated, she recognises and wants to recognise the team effort to that. So fingers crossed for her to ring in the national award next week. And my final information to let the governing body members know is that our annual report is now available on the website, and our AGM is scheduled for the 17th of September. We are going for a different time and venue, so 17th of September, so Tuesday, it's 5:30 to 7:30, and it's going to be in the Queen Anne's Suite at Guildhall 2. So hopefully we'll see lots of people there. Happy to take any questions.
Any comments or points of clarity for Tonya? No? Okay. So Paul, can we come to your Audit Committee Chair's report, please?
Thank you, Chair. Just briefly to update the governing body, on the 23rd of May, Kingston CCG and Richmond CCG had a joint audit committee, which was the approval of the final accounts for 18-19. And for Kingston, just to summarise, they were approved and signed off. So the CCG reported a surplus of 1.084 million, which exceeded the required surplus by 24,000, sorry, and met all the. I wish.
Hope springs.
Yeah, next year maybe. Which met the business rules required of the CCG. Internal audit had not identified any significant issues that needed to be flagged up as control issues in the annual governance statement. And with that, only a couple of minor technical changes. The reports were submitted the next week to NHS England. With regard to the internal audit opinion, there was nothing there that changed or impacted the annual report. And the service auditor reports as well, reasonable assurance, no impact on the control environment. And with regard to the external audit findings, again, Kingston met all three key rules and was green, including VFM. So with that, the letter of representation for Kingston CCG was approved and signed off. And the reports and accounts were submitted. And the audit committee collectively thanked the finance staff and their external partners for delivery again of what was a challenging year, another set of good accounts meeting all the targets. So that was all, Chair. Thank you.
That's great. Thank you, Paul. Any questions or points of clarification for Paul? Yes. No.
Can I defer that to Neil, possibly? Or James?
Sorry. By the surplus, can that be reinvested, or does it get back?
Effectively built up as part of our cumulative cash drawdown, so we can only spend that as and when we get approval, and we won't get that this year.
Okay. Any other questions? Okay. Thank you. So, Iona, you're going to give us an update on Connected Kingston and the metrics.
Thanks very much, Naz. So this was a request to bring back our system-wide social prescribing model that we've been developing in Kingston over the last 18 months to see how the launch has gone and progress to date and to note that. So I thought it might be helpful. I recognise some people in the room know about this scheme quite well, others less so, but it might be worth taking you through a short slide deck to update members of the board about the programme. I'm hoping that we've got it available, or people got the slides in their pack. Okay, I'll talk you through the slides in your pack in that case. Saves me having to ask someone to click the slides on. So for those that you don't know, social prescribing is a generic term used to sort of describe how people are connected with local offers in their local community. So that's anything from things like chess clubs and singing clubs through to, Tai Chi, dancing, all sorts of things. And it's a social connection rather than a health connection necessarily. Some of them will have a health connection by default, but it's trying to keep people network with their local community. And clearly primary care is a prime source of making contact with people. And we know a high proportion of GP and practice nurse consultations, time taken with your reception staff in primary care, is for actually non-clinical reasons. And connecting people to their local area improves their mental well-being, often improves their resilience, the network of people that they can call on. And we know in Kingston we've got a high proportion of older people who are socially isolated. But it works across the life course. It's not only for older people or frail people. It works just as well for young people, perhaps coming to Kingston as students, for example, as well as new families who may feel more isolated when they have a baby for the first time or more than one baby. So those activities, those social activities, largely relying on the voluntary sector, community sector, is something that's we have a lot of capacity in that area in Kingston. We're fortunate with the range of offers that we've got, but what we often struggle is to get the right people through to those offers early enough. So often they are more frail, more isolated, more depressed before we have those conversations. It builds on the NHS long-term plan vision around increased personalised care, as Tonya mentioned to earlier, and it fits in part of that model both with having those discussions, people being more responsible, knowing about what their kind of care pathway, care journey is. Of course, they wouldn't use that type of terminology. You know, what kind of things do they need to be doing day to day in between all the times they might actually come into contact with a health service, and also be part of that decision-making process. And it's something we're quite familiar with when we're looking at the year of care for diabetes, for example, but it's less familiar as a generic offer. So we've been working for some time on what this might look like for Kingston, looking at that personalised care approach, and we've developed a model. It's been largely funded by Trailblazer funding from Department of Housing and Community and Local Government, looking actually around homelessness. So we have not a huge number of people who are homeless in Kingston, but we know that actually intervening early before people become completely homeless actually has much better outcomes for people, rather than them actually pitching up in the Guildhall without any roof over their head, or pitch up on the street, or sofa surfing. So we were able to use that pump priming money to develop this model, and it comprises 3 pillars. So a web-based sort of directory of services and advice and information across the life course. The second pillar is around a network of trained community champions. So that would be people like your receptionist behind in a GP practice, or in a pharmacy, or a housing officer, or a librarian, or a street sweeper, or a community ranger. So people that are having conversations with local people and actually will know about what's on in their own local area, and often pick up and notice changes in people, you know, accumulations of rubbish in a front garden, having a chat with somebody at a bus stop, as well as people perhaps pitching up, as say in a library, for example. And it can divert some of those conversations that perhaps would have had to be had with a GP, and can happen with other people in a practice where you've got people trained up to be a champion. And then the third strand is our community connectors. And in the NHS long-term plan, those are referred to as social prescriber link workers. So we haven't chosen that terminology here, but it's the same thing, our community connectors, and they're currently being provided as part of a pilot in Staywell. So the good news that the model that's required in the NHS long-term plan, a system-wide model, not relying totally on the link workers, so you want to keep that scarce resource for those in greatest need, so those people that can't find services for themselves or wouldn't walk through the door as a stranger to a Babington class, for example. We keep that the community connector, the level 2 social prescriber, for those that need more facilitation, maybe going along with them for the first time, to make sure they actually turn up to some of the offers that are around. It's co-produced with local people, so it was about a 9-month lead-in with various what they call sprints of development, going back to local people, in libraries, in the job centre, so people that actually will be using the website rather than professionals, so it's not too jargonised. It's got a governance. I chair the steering group that oversees the work, includes comms, and reports through to the Health and Wellbeing Board. So in the referral pathway, you've got those that will self-connect, those that are looking for information and advice, and once they know where it is, you can search for it by postcode, by topic, by condition, and find out what's in a local patch, as I say, as well as via the champions and the connectors who do the one-to-one, more personal solutions. I've put a few screenshots in, so I do recommend that you have a look yourself when you've got time. It's www.connectedkingston.uk. You can see how you can browse and look around it, how people can refer, and we have a range of services on offer, some of whom are accepting referrals. In terms of the number of services we've got on the website already, we've got 172 local services, and 53 of those have got the referral button turned on, as it were, so they are signing up to say, we will get back to the person you've referred within 10 days. Clearly, a lot of them don't need the referral element, they just need to know what's on in their local patch. We've had 35 referrals made through the system, and on average about 432 active users a month using the Connected Kingston website. When we look at the higher level community champions, we've had 171 people had that face-to-face training, so they all have half a day's training, and then they go on and do Make Every Contact Count training, which is more topic-based around weight alcohol, physical activity, sort of lifestyle, and how you have those motivating, healthy conversations with people. And once staff or frontline people have done the half-day training, the Make Every Contact Count, and make their first referral through the platform, they'll get a fully fledged community champion badge. So we've got plastic versions at the moment. We've got our first awards of our community champions happening with the Mayor in September. So it's great to have that cohort, because that's where we will get all of those face-to-face contacts happening. In terms of the higher level social prescribers, the link workers, which, as I say, we're calling community connectors, we've got 5 of those. It's actually 6 members of staff. Some of them are working part-time, based in Staywell. In the first 6 months of the service, they had 158 referrals, slightly more women than men, 88 women and 70 men, and 93 of that cohort were living alone. It's an all-range service. It started probably a little bit more looking at those with higher need, but as it's embedded in, it's taking referrals across the life course. So they've had so far 9 people below the age of 50, but those numbers are going up as the pilot rolls out. 41 between age 50 and 70, and 108 between 70 and age 100. And the staff attend our MDTs that are part of the Kingston Coordinated Care model. And as I say, as they embed in, they're seeing an increasing number of younger clients. The youngest they've had so far is age 28. And again, they are taking those referrals. They're working with those people one-to-one. They've had great results with particularly those with anxiety and depression, those that are agoraphobic and, you know, have become very isolated, those that have lost confidence to go out and meet people. And these are people that can often take a huge amount of time in primary care without actually changing outcomes for them. So it's the change in outcomes that we're particularly looking at making the difference. It's quite a difficult model to evaluate, because clearly it's partly people setting their own goals and what success looks like for them. It's very personalised, but we are capturing that with our outcome stars model. It also fits with our Macmillan social prescribing pilot, which is a very similar model. It's just been kept to people living with and beyond cancer and their families, which, you know, increasingly is a bigger and bigger cohort anyway. When we look to the future, the 5-year framework, we know within our primary care networks there's funding for social prescribing link workers, so our community connected service, and it's one of the roles, these new roles, for which there's 100% funding. So we're working with the new appointed elected clinical directors. I met with them last week to say how can we use what we've got already and build on that for the future and look at keeping it a system-wide approach. So a commitment from those clinical directors to work together on this. Clearly, we don't want to lose the strengths that we've got already and continue it going forward. So we're developing a local plan. It will fit the primary care network model. As I say, we want to build on the strengths that we've got already, and also supporting our local community and voluntary sector network. Happy to take any questions.
That's a real big whiz through, isn't it? It's just, there's a lot of work that's going on. I've got a couple of things before I open it up, if that's okay. It's really good news about the PCNs, when you mentioned before, but have you got timescales on when they may or may not sign up?
So we committed, last week's meeting was the first meeting, I think it was the first meeting they'd met face-to-face as clinical directors, to be honest, and clearly only formally became in that role from yesterday. We said that we'd meet again, I think, in about 3 weeks' time to take it forward. We're conscious the pilot currently runs out in mid-September. We don't want to lose that workforce. One of the requirements from the NHS plan is to do a kind of baseline workforce audit, but because none of these are permanently funded posts, while we will be declaring them, we will also be making it clear that these aren't roles that would be continuing if we weren't able to use the primary care network funding. So we haven't, formally signed any memorandum of understanding or anything yet, but the commitment in the room was there across the board.
That's really good news, thank you. And lastly, about the evaluation from Healthwatch Kingston, have we got any idea about what kind of metrics? Because obviously something like this is really difficult to quantify the value, but actually the soft elements are really very important on this, but I'm not sure how that's been taken forward.
So one of the things they're doing is having to go back to people that have used the social prescribers, the community connectors, and ask for permission to then contact them. So those that have seen those patients are going back, and they've often built up quite a bit of rapport. I guess we can't guarantee if it will be 80% that say yes or 50%. But once we've got that permission, then Health Watch are contacting them directly and going through a sort of framework of the difference it's made and recording that. The benefit with the new SNOMED codes for has social prescribing been offered, has it been accepted and has it been declined, is that hopefully we'll be able to track through, do you have fewer secondary care appointments or GP appointments for people that chose to accept the social prescribing. It would be lovely to link other outcomes to that, you know, lower blood pressure a year on or whatever, but I think we're a little bit far away from that just yet.
Thank you very much. So, Catherine.
Thank you. I just wanted to ask two things, really. You talked around the training they receive for the level 1s and 2s, but you didn't mention, I assume that's already there, but safeguarding. Is that part of their training is the first thing? And the second thing I wanted to ask was around who supervises their practice and how do you kind of assure that they're safe, effective, and actually when they're dealing with more acuity and more complexity that they're confident to do that appropriately?
So the active signposts, the community champions, have just a level 1 safeguarding discussion, if you like. It's not a formal online module as such, because it's the same as if you were meeting them in a library anyway. It's talking about the local offerers, and they would already, if they had a concern, raise it with their manager. The level 2 social prescribers, the community connectors, have, I think it's the level 2 safeguarding. They are managed by a manager in Staywell. They work as a team. They've got quite a range of skills. So we've got a nutritionist, a couple of counsellors, exercise specialists. So actually as a team, they've got quite a good range of skills, but they are getting both their line management and their practicing sort of peer-to-peer support and one-to-ones with the manager in Staywell.
Would the supervision model of practice that you've just suggested be part of the evaluation, that they feel supported whilst they're enabling others? I'm just thinking in terms of kind of...
Yes, I think actually the evaluation is more of those people, the users of the service, rather than the professionals. But it may be something that we want to say, is this a model that's working, given it's one that we want to continue? How is that for them as a staff group? Because we are, you know, we do know that they are seeing those with more complex needs.
Thank you. Atin.
Thanks, Chair. I know you touched upon the Macmillan Cancer social prescribing pilot, and we've been really fortunate to have that funded by Macmillan. It's coming to an end some point this year. I was wondering, as a way of continuing that, is there a plan, or I suppose how can we plan rather, so that the work being done by that can be taken over by the social prescribers? Because obviously in the cancer forward view, there is a lot to do with cancer care reviews, and I think they could really help with that.
Funding, sorry, we've got for link workers will match, including the social prescriber for cancer. So whilst we've got funding through to January for that, we would envisage that the role, the function, we'd have an extra health link worker that would be covering the work. Because in reality, if you see it as long-term conditions or the types of conversation you're having, it's exactly the same whether you're doing it for cancer or whether you're doing it for any other person coming through the door. So we'll aim to have 5 whole-time equivalents of the link workers, and including the Macmillan one, we'll take it up to 5 as well. So it's a like for like. In fact, all the link workers will be able to work with people with cancer, just being one.
Okay, that's very encouraging. Thank you. Any other comments or questions from board members? Gareth.
Yeah, just quickly, I think I agree with you, Naz, that feedback on this is difficult, but just from a sort of patient point of view, I've had through the MDTs some use from these community connectors, and they've been extremely useful for people who've been really struggling in, not just elderly people, but young people as well with complex medical problems, and they've been really helpful and found it very beneficial. So I just wanted to feed that back in, and that's only been in the last 3 or 4 months.
And I think being able to capture some of that would also be great, because, metrics only go so far, knowing it's relieving, staff pressures as well would be helpful to try and capture. So I'll maybe try and pick that up too.
And also I must apologise for when I put the AGM in my diary, I think I've invited everybody in the room to come to the AGM by mistake. So I'm trying to delete it now. I do apologise.
Thank you, Gareth. We look forward to it. Right. Okay, Julia.
Iona, Iona, I'm aware that collectively the CCG and the Council commissioned Active and Supportive Communities, which was sort of a precursor, I suppose, to social prescribing. And I was wondering how we might be bringing that together and whether we're having that conversation, because I remember that a lot of the feedback around the expectation for that contract management was around case studies. So I'm wondering if we've got some rich information that we can also bring together, because I think there's an opportunity to do a broader offer with whatever, where we are with Active and Supportive Communities, which must be coming to year 3. End of year 3. Thank you.
Had a conversation just about it this morning, to be honest. So the Active and Supportive Communities was about the commissioning that we make to the voluntary sector. So what they provide, it brought a range of voluntary sector providers together to work in a collaborative way. I think if we take up all of our extensions with those contracts, it runs out at the end of March 2021. So it is something that we're looking at as a council, and we raised the very point that we should look at it alongside the NHS, because I think if we want to make our local public pound, if you like, go as far as it can, working collaboratively both with the council and the NHS on our commissioning of the voluntary sector makes it much more likely to join up. So we'd like to sort of explore that more as the next phase, the sort of what happens next with Active and Supportive Communities, and also making sure it's still matching our priorities. Is it supporting as much of our small organisation as it does over our, we've obviously got some very large voluntary sector organisations in Kingston, so how it works for the whole system to deliver the best outcomes for residents stroke patients. So it's something I think we should be working on now, because in reality March 2021 will be here before we know it, so it's looking over the next sort of 15 months how we work together on that.
Thank you. Any other board member comments or questions? No? Rob?
That's a very good point about the bins, Mr. Rob. I'll have to look into that. I mean, I know some do advertise on the side of the bins. We obviously have a waste partnership with multiple boroughs. Yeah, possibly the bins too. Plenty of those around. So yes, I think how we promote it, clearly we've been developing it. We didn't want to launch it until it was fit, so that when people went on it, they could use it well. If you don't get a good first experience, it means you don't tend to go back, because we've been doing it with groups of local people and then polishing it, if you like. We're at the next phase of launching the even better version of the platform. Just to say, it's also all on open access. So we work with an organisation that we're happy to share it. So if other areas want to use what we've done, it won't cost them anything like the same amount of money to do it, because it's all public money that's created it in the first place. In terms of your first point, which I've forgotten already, Mr. Telephone number. So we're trying to not put telephone numbers, because we don't have a sort of Kingston Voluntary Action sitting there at the end of the phone to direct people. We're driving it such that either the community connector that you have the conversation with would be able to connect you with the service straight away for those people that don't use the website themselves. It's all very accessible either on a phone or on a tablet, so having trained reception staff in practices, we've got one practice doing that. So if somebody needs a longer conversation, they get diverted to that member of team rather than the one that's welcoming people coming into the practice, that actually they would be able to make the connection with them there or then. The cost of having somebody waiting at the phone or leaving messages and calling back actually breaks the model down. I can certainly speak to our customer contact manager to say actually if they needed to direct people where they'd be able to find a local community connector or champion. Yeah, what's there?
Okay, thank you. That's very helpful, Rob. Thank you. Any other comments or questions? Sorry. Yep, ask a local authority for some advice as well. Okay, thank you very much. So this paper was just for noting, so thank you very much, Iona. Julia, I think we're coming to the local health and care plan update.
Thank you, Chair. I'm pleased this afternoon to be talking to what is I'm now calling the penultimate copy of the Local Health and Care Plan. Iona spent time, thank you very much Iona, over the weekend doing some final review of the document that got sent out to everyone on Friday, and there are a few changes that we need to make, not in terms of content and the spirit of the document, but actually just a way we want to put in moving some of the wording around. So as some colleagues around the table will recall, the plan describes the local vision, priorities and impacts to meet the local health and care needs of our local population here in Kingston, and has been a plan that's been developed over time. It's based on a case for improvement that was presented to the board, and then out of that we identified our priorities, and then on that basis we went forward and built and co-designed with local people the actions and priority and impacts that were important to delivering those priorities, and that's now will come together in the final document that we will be publishing later on this summer, and is part of the information that will be supporting of Kingston as a place in the long-term NHS plan response that Sarah referred to earlier. This plan, as previously explained, is not all of our strategies and not everything all organisations are doing, but is those areas that we consider are very important as partners to be working on together. So the plan has come to you for any further discussion points, but for approval. As I said, it outlines what is our case for change, what are our wider determinants, what local people have told us. There is a section on the financial context which Sarah Ireland, the Director of Finance, is just signing off for the borough. And the plan looks at the challenges that we have and also how we're going to manage those priorities across the life course of Start Well, Live Well, Age Well. We've also strengthened the prevention and early intervention section, so it picks up on the first 1,000 days, because that was considered to be a very important area, also refers to and reflects on social prescribing. And then another area that we felt was very important to identify was that, and pull out the role of unpaid carers who contribute significantly to the care of people in the local borough, be it their own loved ones or being it good neighbours who pop in or and support individuals. The other pieces of, we also refer to all the other pieces of work, and the document will have a number of links in it so that it's an easy access. And also we have started to talk about some of the enablers around digital estate and workforce that will come out as we go through developing further the actions and the components that will deliver the plan. And then the final section refers to the delivery and governance of the health and care plan. As said before, a lot of what's in the plan is work we're already doing. However, we do need to strengthen that. We do need to pick up pace in some areas. And so the plan will be reported into the Health and Wellbeing Board and into the governing body and other partners' organisations. And we're in the process, or I'm in the process of pulling together the implementation plan, which will map all of the programmes of work and identify which organisations are leading on the pieces of work. And then, as I say, it will be reported through to different groups and boards. What you've got in terms of the design of the plan, it's not the final design. That's going to designers, will be taking forward the infographics, the icons, and some of the pictures that we use as part of the slide decks. But it is here for the content rather than for the design. The other thing that the other paper that was also sent out to everyone on Friday was the You Said We Did. As part of the consultation and the engagement that we've undertaken on this plan, we had a number of comments that came back from local people, and we'd really valued all their contributions and feedback. And what we've done is start to map how we've responded to them, either put them in the plan. They'll either go into the implementation and taken forward by the programme managers, or they may need a slightly different response, or they're for noting. At this moment in time, this is what we've pulled together in the CCG, and I'm going to be working with other partners just to refine that, and that along with the engagement report, will be 3 documents that will underpin and will be the suite of reports that comprise our Kingston Local Health and Care Plan. I think that was all I was wanting to say this afternoon. I don't know if there are any points of clarification or anything else anyone wants to add. Iona, I don't know if there's anything you want to add to what I've said before we take any comments and we move to approval. Thank you.
I think it's just to reflect the journey we've been on to create the plan. You know, I think the amount of engagement we have, it's always hard to go from lots and lots of vision to trying to bring it down to a manageable content. I think re-emphasising the point, it's where we're going to make the biggest difference together. So I think from a council perspective, it's great to have, you know, the final plan there, the priorities that we've agreed on, and the action plan that will come from this on how we're going to take forward the Start Well, Live Well and Age Well. So, you know, I think it's great to be at this stage now and look forward to the work ahead.
That's great. Thank you very much. There's been an awful lot of work going into this, so thank you so much to you and your teams for pulling this together, and also the engagement process I think has been quite phenomenal. And having been part of some of the workshops and the engagement groups around with the local authority, I think it's been a very good piece of work. As regards comments and questions around the content design process or the next steps, have we got any questions or comments from board members? Catherine.
I know I said this before, but apologies. But under Action 5, which is to support people to manage long-term conditions, it's just under the impact, because as we're aware that sometimes other people, another significant person has to look at someone else and to kind of comment as to whether they might be deteriorating and to support that. And I just like to sort of see that as an element here, because it may be someone else who's supporting somebody with a long-term condition, and it was just to clarify that, really. And I'm sure that's something that's already been considered, but when I don't see it here, it just makes me ask the question.
Right, I think one of the things that we decided to do as well was right across the whole board talk about the carers that actually support it's just above the impact levels. So there's a line that goes right across and straddles all of the areas. So we try to find a way of actually putting that in. But I completely take your point that it does need to be quite prominent.
And also as part of the work that will be taken forward with taking these actions will be consideration of the unpaid carer role in contributing to the delivery or the model and the services that are being developed. So they will be part and heart of that, along with the whole prevention and early intervention. They are cross-cutting themes. And the section on unpaid carers, there is a carer strategy that we are reviewing here in the borough. And so from that point of view, we will be strengthening that component as well.
I think it's a point well made, because it was brought up in the workshops that we had before as well. Any other comments or questions from board members? No. Anything from the public? Right, so the governing body are asked to approve the content, the design process, and also the next steps. Are we happy to approve? Yep. Okay, thank you very much. Thanks, Julia. See you. Bye. Thanks, Anna. Okay, so if we can come to the CQC SEND inspection update, is that for you, Julia, again?
So following the SEND inspection in September last year and the requirement of the CCG along with other partners to produce a written statement of action, what we've been doing on a bi-monthly basis is bringing an update report to the governing body with regards to special educational needs and disabilities. And so this report today very much focuses on the current position and where we are in terms of the appointment of a permanent DCO, that's designated clinical officer, and the substantive person starts in September. But in the interim, we have two people covering that role, delivering elements of the DCO activities, such as attending the special educational needs panels and undertaking some of the quality assurance work around education, health and care plans, and in providing the health advice as required. And also participating in developing the quality assurance framework, which was one of the areas that was called out as part of the inspection report that we had across the Kingston area. So we've now got the DCO in place, and they've been working, as I said, attending panels and also working within the team, within the borough, to actually improve the joint working. And one of the areas is actually working with the healthcare professionals to actually strengthen and understand their role in the developing of the health and education plans. And also any mediation and tribunal meetings and panels that are required. There are regular meetings now happening both within the local Kingston patch, and also they are linking into what's happening across London. So we are learning from what others have done and actually bringing some of that work back in. And as you can see on the third bullet point on the activity progress update, the designated medical officer continues to receive on average 16 requests for medical advice for education, health and care plans each month. And there is quite a turnaround time to get that information into the health and care plans. One of the challenges is actually obtaining information from the health questionnaire that's not been completed by parents or at the referral stage. And also the child may not necessarily be known by a community paediatrician or therapies working in our specialist services, and therefore actually trying to gain some of that medical and clinical and health information can be quite challenging. And so the request of board members and other GPs who may be approached is if they can facilitate that would be greatly appreciated. The other big area is the quality assurance. As I said, we were called out with regards to the quality and the completeness of the health and some of the social and educational information that was put into the educational health and care plans. And so actually we've been working on that to strengthen that quality assurance and having reviews of the content that's going into the plans to ensure that it is of a high quality and actually can help support and inform the education, the health, and more importantly, the health component of that education, health and care plan. And the report outlines the number of requests that have been received. Two other important pieces of work are the therapy services review. Again, the written statement of action called out concerns with regards to the therapies weights that children with special educational needs and disabilities have in gaining access to communication and language support, such as through speech and language therapy, functional skills from occupational therapy or mobility with physiotherapy. And so one of the pieces of work that we're doing both across Kingston and Richmond is looking at what the therapy offer is and what the therapy model is, so that we can move to a new jointly commissioned model with the councils and Achieving for Children and local providers and children in that co-design from next April. There was a very positive discussion at the Send Futures conference that was had last week, where parents were very positive about some of the emerging thinking around the approach that the therapy review group were putting forward. And so we will take forward that work with a view to having a finalised, co-produced model by September, which will inform commissioning for 2020-21. And the other piece of work that we're doing is actually pulling together a performance dashboard that looks at all the component parts that are important around understanding the performance around this area of children with disabilities, so that we can actually monitor our progress. So that's a very quick update to the governing body in terms of the current progress and the work we've done in response to the written statement action around the designated clinical and medical officer roles and the therapies review. And I'm happy to take any questions, receive any comments. Thank you.
Okay, thank you. Sarah.
So firstly, obviously, historically, this was something that was a little bit off our radar prior to the SEND inspection, and I think that this has progressed significantly, I think, from where we were. There's obviously still quite a lot more to be done, and we need to, I think, regularly have updates at the governing body and continue on that route so that we don't lose it again. But I just wanted to thank Tonya and the team, because I know what a huge amount of effort everybody in Kingston has put into this to get us to this position, and I do think this has improved significantly, although, you know, still more to do. But yeah, I think it's good that we have taken action where required, and I think this looks as if we are progressing forward quite well.
Thank you. Phil?
Yeah, I echo Sarah's words. You've done a lot of work. I've got a specific question. One of the things there's quite a lot of talk about at the moment is services for PTSD, post-traumatic stress disorder. And I don't know if you have a feel or any actual figures for the proportion of kids that come through this kind of service who have PTSD or might need access to services for that, because that needs to be taken into account with the therapy services review.
I'm not aware of any numbers, but there might be some numbers that flow into the neurodevelopmental service. I'm more aware of PTSD in adults.
But there is good evidence that children often do suffer from PTSD and need intervention, and I'm not sure the neurodisability services are necessarily set up specifically for that. And I'm just raising it so that it can be looked at as part of the review.
I think that's one of the roles that having a DCO actually we can start picking them up with that, and actually they can start looking at some of what's coming through the health and care plans, that general conversation with clinicians around what kind of presentations they're experiencing. So I think that's why we can ask them to have a look. So
that's great, thank you. Any other comments or questions? I've just got one question around the dashboard. So the dashboard, I'm presuming, came out of the written statement of action. And if so, or, well, whether it is or not, but would there be a possibility of the board actually receiving, not the dashboard, but actually assurance that things are progressing according to the timescales, and if there are any issues that need to be highlighted where timescales are starting to fall behind?
So the dashboard, there's always been a lot of information, we're pulling it together. And one of the things that I'm more than happy to share with you is how we are demonstrating delivery against that. The other thing we do, I have just received, is the second summary report from our review with CQC and Ofsted, that we have quarterly meetings with them, and we've got one pending in the next couple of weeks. So I'm happy to share that also with governing body as well.
Helpful. Thank you, Julia. Any other comments or questions from board members? No? Rob?
I really think that's a role for education, because it's all to do with the funding they receive for. So I don't think that's a health funding issue. So it's what the Department of Education allows for special needs. And you're absolutely right. If we had the conversation with schools, they would say their funding for this is being squeezed. So it's not a health funding. Yeah. But I think they're very aware of the issue. I think they're very aware of the issue. The local authority and the FC are very aware of the issue.
Okay, thank you. Unless there's any other questions, we're happy to approve the direction of travel and receive this update, and we'll look forward to receiving future updates as well from the governing body. So if we can come to the end of life care. So, yep. So, Catherine.
Okay.
Oh.
Santosh, are you going to come and join as well? Right. It is, yes. So I'm very pleased to introduce Catherine and Santosh, who tell you a little bit more about who they are, who this afternoon are going to come and give you an update on the end-of-life care strategy that we've been developed and implemented across Kingston and Richmond. So I'm going to hand over to Catherine and Santosh now to introduce this item and give us the update. Thank you.
From Catherine Millington-Sanders, End-of-Life Care Commissioning Clinical Lead, and this is...
I'm Sandra Springer, the Commissioning Manager for End-of-Life Care.
And would also like to give thanks to the huge number of people on our steering group and obviously all the sort of frontline staff and patients that have been involved in developing the strategy. So if we can just go through the paper. So really the purpose, core principle of our approach is about using quality improvement methodology, participation and co-production with frontline staff and with people who are approaching the end of their lives and those that are important to them. The reason for coming to the governing body review today is to basically ask people to note it, note the progress, and also the against the planned pathway for end-of-life care with the strategic recommendations and actions during 2018 and 19 and some of the developments for 2019 and 20. And in summary, I'll repeat at the end as well that it's basically to note this for progress. So as a brief introduction, 1 person dies every minute in the UK. We've got an ageing population, and the newest Etkind and Owl evidence is that this will rise by 17% by 2030. We have 0.5% of our Kingston population dies each year, so it's roughly over 1,000 deaths every year. And that's on average 3 people every day. 54% of people die in the community, but still 46% are dying in hospital. Of those 46% that die in hospital, around 40% of these are expected deaths. So that means basically that we could do a lot more planning in order for people to achieve their preferences of care, where they would like to be cared for and where they would like to die. So there's a really important piece of work that we're trying to do to be able to manage people's preferences. People in the last year of life also have 2 to 3 hospital admissions, and as noted above, many of the times those aren't necessarily what they're actually wanting. And so to improve patients' experience and outcomes by offering them the opportunity to share those preferences with them, we're trying to, we've got a number of approaches from the strategy and our strategic recommendations in order to achieve that. I think it's worth noting that Coordinate My Care is an important aspect of that. It's, for those that don't know, it's an advanced care planning specific tool for urgent care records that are particularly important for people that are nearing the end of their life and noting carers that are important to them or people that are important to them. Currently, we've got 1,341 patients that have an advanced care plan on CMC, of which 197 were created in 2017-18, and that's really significantly increased to 504 in 2018 and 19. That's been one of our strategic directions that we've been trying to increase over the last year, and so that's really, I think, our efforts and the steering group's efforts and everybody in the front line have really achieved great bounds with that. I think it's about 70% of people that's been achieved in primary care. So again, some of the planning from a commissioning perspective has actually really paid off dividends. Of the patients who died with a preferred place of death recorded, 74% of those with the CMC record in place have actually achieved their preferred place. So again, realigning the mismatch of people that die without a care plan often tend to die where they don't want to. And if we put that in place and we've identified people in the right time at the right place, then they are achieving more of what they would like to. So our focus during 2018 has been on implementing our planned priorities. So those are summarised on a plan on a page. I think it's page 7, essentially, for us. It's the one with the pretty diagram. That's 63 on the governing body papers, and it says... Okay, we'll come to it anyway. So, for reference, this is it. Little organogram. So just running through that, our main objectives are community development. So an example here is compassionate neighbours, but really it's looking on a strategic direction to work with all of our community development, so from peer support groups right through to schools, places of worship, places of work throughout the whole of our community effectively, and raising the profile of the importance of end-of-life care and bereavement support. Person-centred and holistic advanced care planning. One of the end outcomes of that we're measuring is coordinate my care plans, but basically it will be about looking at the quality of the care plans as well as the numbers, obviously. Improving experience for patients and those important to them, in addition to trying to monitor how frontline staff are feeling about delivering end-of-life care. An important aspect of this that we've been strongly, I'd like to thank Public Health who have supported us in this, is looking to reduce the inequalities for end-of-life care, so for access and the people that often get variations, so people noted in the CQC thematic review, and effective commissioning using quality improvement for end-of-life care. Our key progress, just to summarise, against our planned strategic objectives are over 500 more residents have an advanced care plan on CMC. In Kingston, implementation of the Red Bag scheme, so this is specifically in care homes, has reduced the length of stay by an average of 5.2 days for care home residents admitted to hospital as an emergency. Training and education has been delivered to primary care and community staff on advanced care planning, and we've got increased plans to develop that across all of our sort of providers. And 24 Kingston residents, so for a new scheme from Princess Alice, which is about helping match compassionate neighbours to the right people. We've got 24 new Kingston residents and many Kingston people trained to provide social and emotional support in the community. So again, this is for noting, and we'd be delighted to take any questions.
That's great, thank you. Sorry, thank you. So there's an awful lot of effort and an awful lot of work that's gone into the background of developing the strategy. So thank you very much for doing this. It's very, very clear, clear reading and very clear presentation on this. As regards comments and questions from board members. Yes, Jim.
I think this is wonderful. This is a really clear explication of what we're doing for some of the most vulnerable people who need to feel that their wishes are being understood and taken forward. The thing about strategies, of course, is you map them onto the real world. So where is the real world creaking? What's your experience so far of actually, in terms of putting these new care plans into operation, of where you're having most hiccups and difficulties?
So I think there are a couple of points specifically around care planning. It's about increasing the identification of people. So I think that there's not one sticking point. I think it's across all of the providers. But what we can see is when we start to make a raised focus effort from the steering group going back to their individual providers, we're able to raise the profile within each of those providers. So, for example, Kingston Hospital's done amazing work of doing an advanced care planning leaflet, so we're gradually seeing an increase there. I've been going and liaising with lots of the practices, and we've seen that there's been an increased focus there. So I think identification, then supporting the carers, we're definitely noticing once we start to increase identification on a register, then you can start to note the carers affiliated with those people that are important to them. I think having robust processes across general practice and within the hospitals, just having simple reviews of procedures and processes that are in place that make it easier to identify, make it easier to know that everybody's got a care plan when they need it, is probably one of the sticking points. But again, we're noting that with training and education processes to try and embed it. I guess general workload and workforce pressures are probably the main sticking point. We're all having to do a lot of work, and this is a part of it.
And just to add for me as well, so we've got general practice creating care plans, and the hospitals are doing it as well. We would like to move to care homes also doing it, but at the minute they have to go through some IG requirements so they can have access to the portal. So that's something we're working on across South West London to sort out. Also, primary care have said to us that most people receive the discussion favorably, sometimes they don't. So one of the things that CMC's done, they've added a functionality to their portal called My CMC, where patients and family can decide to start the care plan themselves, and then once they've started it, it triggers something in the practice, and the practice, they have to go and see the GP to finalize the plan. So hopefully, as time progresses and we do more comms and engagement about this issue in the with the public and with patients and carers, that the discussion becomes less daunting and scary and just as a routine part of care. And so that's another issue as well.
So I'll just add in a couple of points. Just on the last point, talking about death and dying matters weeks, it's always been really, really difficult to bring it up as a social topic. And I think that the more we normalise it as it is a normal process, the more we normalise it, the more we will be able to start those discussions. The other element that I think has been difficult in the past is the quality of the care plans that are being produced, is that there is some variation, that most of them are produced at very high quality and also have very specific instructions within them, which are really helpful for emergency services, out of our services. But there are still some care plans which are being produced which are just tick box exercises whereby they just provide the demographics of the patient and actually no information which is really useful. So that's sort of one of the aspects that we are still working on. So Catherine, you wanted to come to it?
Sorry. I just wanted to ask around, as this is obviously for adults and children, I note that the progress against each area, but I can't see progress made associated with children and young people exactly, and I just wondered what sort of activity there is around that.
So we've been liaising with the teams, the children's team lead, so Susanna Lack, I think it is, who's one of the leads. What we've decided to do is so in the work streams, it falls under basically inequality groups. So in order to make sure that we could maintain a focus on it discreetly, actually it falls under there. So it will be one of the, because it's been recognised as an area of having inequalities, obviously it's in the long-term plan as well. So it will fall under that, and then we'll start to see hopefully more outcomes that are physically coming from that.
And there's just another quick question around the leaflet that was created. Is this going across age ranges? Is this again something that will translate? Is this something that, because as I see this obviously the stats are specific to older people, the emphasis around community matrons, care homes, etc., last year of life. But I'm also thinking this is obviously a strategy for children and young people as well as older people. So it was just to sort of see that language, I guess, and some of the activity associated with that.
I don't know what's easier. I can probably share the advanced care planning leaflet. I can't remember off the top of my head if it spans both stages. Having spoken with the paediatric team, though, they have a very specific end-of-life care strategy that's separate to the adult end-of-life care strategy group. I suppose our ambition is how do we bring those two together and also be able to maintain some of the individualism that is needed to be able to personalise it for children's services. But probably we'll need to do more liaising with the specialists in the hospital to be able to do that. So we could bring that back to you perhaps another time, but I don't have the answers now.
Okay, any other comments or questions? No. Fergus.
So I was just going to add, building on the paper that I've got coming up next about child death overview processes, just to confirm that as part of our preparation for the new arrangements, we have made a specific investment in bereavement support services for paediatric deaths and the families. So that will be in partnership with the paediatric department based at Kingston Hospital, covering Kingston and Richmond. And that post and its function will link in then with the paediatric outreach nursing team, the cancer nurse specialist for the paediatrics, and the bereavement midwife who's already in post. So I'm really pleased to say, as part of our strategy, we're on the front foot in that regard. But I'll talk about that a little bit more when I talk about the child death overview process next.
That's really helpful. Thank you very much. So any other comments or questions from board members? Okay, Rob.
That's such a good question. We don't have all of the stats, so I think as part of something that Santosh and I have discussed, we'll be liaising with the practices with a newsletter to actually ask exactly that. So it's the Royal College of General Practice that holds the information, but we will be asking them and sense checking. Thank you.
Thank you. Unless there's any other comments or questions, this is just for noting. So thank you very much, and thanks for all the hard work that you guys do, okay? Thank you. Right. Fergus.
Thank you, Chair. So this paper has come to the governing body today with 2 sections and 2 requests of the governing body. So the first part is the Children's Safeguarding Child Death Overview Panel arrangements, and that particular element we are looking for the governing body to agree and approve the arrangements that we're proposing for South West London. And the other part is just to draw the governing body's attention to the changes around safeguarding children's partnership arrangements, and that's for the governing body to note those. I want to start off in terms of the Child Death Overview panel arrangements by thanking Gwen Kennedy, who's the Interim Director of Quality for the South West London Alliance. Gwen has done an amazing piece of work over the last 12 months, getting what are very strongly held local ambitions aligned and coordinated in a way that we will have one system operating across South West London, and partners have agreed to and signed up to that. That's no mean feat, so I particularly wanted to just say thank you to Gwen for that. As part of the statutory guidance working together to safeguard children, there's 2 particular ambitions that programme wishes to see happen. One is to improve the support for bereaved families following a child death. And the second is to make sure that information is aggregated and collated at a system level better than it has been up to date. So one of the key drivers behind the new arrangements for South West London is to be considering enough cases where there would be information and learning developed as opposed to small samples or small learning opportunities. So within the Kingston area, on an annual basis, we have somewhere between 10 and 12 deaths, whereas across South West London, we have about 100 in total. The guidance recommends that the child death overview process should be considering as a minimum 60 cases, and therefore part of the rationale for us working together across South West London is to recognise the learning and the opportunity for learning and dissemination of that learning would be greater if we worked on a larger scale. Within the report, I highlight a number of the important changes. So one of those is the responsibility for child death overview process moving to partners led by health. And as I say, we've been very closely liaising with our local authority colleagues to come with a system that covers not just Kingston and Richmond, but also the South West London area. I've mentioned the merger of the existing panels, but we will continue to work closely with our colleagues from health, social care, the police and other partners with our local multi-agency child death review meetings. As I mentioned in response to the question on the end-of-life care strategy, we have made provision for investment in the key worker role, acting as a single point of contact for families, but also in partnership with Kingston Hospital Trust to invest in some additional bereavement support for families within the paediatric nursing team. The last element then to draw to the governing body's attention is about the requirement to submit data through a national database. And we do that through a piece of software called eCDOP. We have funding in place for that through until April 2020. At that point in time, CCGs will need to pick up the funding that has been made so far by NHS England. It's a small sum. It's about £5,000 to £6,000 per CCG. I'm not anticipating that there's any difficulty within that. But importantly, within the paperwork, there's a second section which has a bit of a pink banner. So I'll just wave that so people know the section I'm referring to. I haven't got it electronically in front of me. So this is the published arrangements for the Kingston and Richmond Safeguarding Children Partnership. So this is what was our Safeguarding Children's Board. This is with the governing body today for them to note, as it's already been approved outside of here through the local authority as lead agency for publication of this. And I want to mention specific thanks to Sarah as our accountable officer for taking on that responsibility in terms of endorsing this approach, but also as the single accountable officer for South West London, this is part of her responsibility, and we have a role to make sure that we discharge her duties through us locally to the best of our ability. So this partnership arrangement, there's a requirement that we published by the end of June. It's come to us a couple of days after that publication date. And it has been developed with the local authority, police and CCG newly regarded as equal partners in the new statutory arrangements. Historically, the local authorities have played a lead role, both in terms of activity and funding and management of this process. I think probably the thing I'd want to say to the governing body is for us to be very clear in our minds that that has shifted. There's an equal responsibility now onto local CCGs and governing bodies to ensure that they discharge their duties equitably amongst the partnership. So that's a summary of the two papers that are contained within this section of the agenda. The first is to ask for your approval for one, the arrangements for the Child Death Overview Panel. And I'm happy to take any questions.
Great, Sarah.
Yeah, so thank you. And I know you keep thanking me, Fergus, in all these meetings for taking on the accountability, which obviously is part of the requirement. So as accountable officer, I do become accountable jointly for this across the partnership. I did think it was actually worth pointing out that this is a change, because we've always had an accountability around safeguarding, as I have as accountable officer. The difference is where we had the lead organisation, where the council in safeguarding in previous years, this is now a joint partnership responsibility with the police, ourselves in health and local authorities. And that's the significant change, as well as the changes to the structures that we're making. It actually is a joint now leadership for this, rather than a single agency leading. That's correct, isn't it? I think it's worth just pointing that out.
Yes, ma'am, that's absolutely correct. And I guess one other thing, just thinking about that, adding in an element around governance and reporting. For the child death process, whilst we will obviously have that arranged at a South West London level, reports on that will come back to our local Safeguarding Children's Partnership, which is jointly across Kingston and Richmond. There is a learning and development subgroup of that partnership, and therefore through that route we'll take it back to our local system and also to our Health and Wellbeing Board. We produce an annual Safeguarding Children's report, and this will form part of that. So that local learning, but also local understanding of what's been happening with population will come through that route too.
Thank you very much. Thanks, Fergus. Comments or questions from board members? Catherine.
Can I just ask a quick question, Fergus? The key worker role, do you have a sort of timeline for that?
So this is, I guess, a change in terminology and a little bit around what the function is, but we do have a single point of contact, child death coordinator post already in place. The current post holder's on maternity leave, anticipated back within a couple of months, but we have an interim arrangement in place at the moment. Our plan during that period of time, shortly after the substantive post holder returns, is that we'll relocate that post into the team based at Kingston Hospital. So medical, nursing, bereavement support and the administrative support are all co-located within one area. So yes, we do have somebody in post, and we've got a contingency plan going forward.
Great, thank you. Any other comments or questions from board members? No? Okay, so we're asked to approve the arrangements proposing for a South West London Child Death Overview Panel. Are we happy to approve this? Yeah, okay, so approved. And note the new working arrangements when it comes to the local Safeguarding Children's Partnership. So we're quite happy that we're aware of this now. Okay, thank you. Thanks, Fergus. Okay, so I think you're up next again. So Integrated Quality Governance, Committees and Comment?
I am indeed, thank you. So this is your hopefully very familiar Integrated Quality Governance Committee report covering performance and quality. You'll note from the summary sheet on page 5 that actually we're doing extremely well for this stage of the year. A couple of areas I specifically wanted to draw attention to. So our estimated diagnosis rate for people with dementia. You'll recall in January time we had a deep dive here at the governing body, and I'm pleased to say that our figures for the last 2 months have improved month on month. I'm looking forward to seeing that going from its underachieving to overachieving, hopefully soon, sir. The next area I just wanted to draw attention to was with regards to the accident and emergency waiting time. So this has been a persistent red for us on our performance scorecard for some time. And I thought it helpful just maybe to just talk in a little bit more detail around that, building on some work that has been done at the Accident and Emergency Delivery Board. So the A&E Delivery Board covers Kingston, Richmond and the East Elmbridge area of Surrey Downs as well. It's a multi-agency, multi-partnership board, and indeed some of the governing body represent us there on a monthly basis. One of the areas that they've been particularly focusing on over the last couple of months has been closing down the actions that were identified for last year and then starting to look at some of the actions required for this coming year. And partly that's driven by the performance discussion, but also to try and get a deeper understanding as to some of the underlying issues beneath the growth in attendances. So for Kingston Hospital, they've been looking at double-digit, in excess of 10% growth year-on-year attendances over the last few months. A piece of work has been done and shared with the with the delivery board, trying to understand some of the reasons behind that, and I guess it's multifactorial. Some of it is perceived around reputation, so it's got a very good CQC rating and it historically has delivered very high quality services and in a timely manner. The urgent treatment centre itself, it now regularly sees all of its patients within a 2-hour period rather than the 4-hour period that the 4-hour standard determines. A number of the patients, in terms of looking in more detail at the types of patients who've been attending, a lot of them are not accessing their GP first or not even attempting to book with their GP first. And the growth group has historically we've looked at paediatrics and elderly patients, but actually over the last period it's been working age adults and predominantly in the afternoons and evenings as well. Another area where some further work needs to be done to evaluate what's happening is the number of people who've been presenting and their discharge identifies that there was no problem identified, that there was no physical need met by the attendants at the A&E department. And each quarter, there's usually around 3,000 out of the 25,000 patients who present who would fall into that clinical coding category. But in the first quarter of this year or the last quarter of last year, January, February, March time, there's 100% growth in those two numbers, 3,000 versus 6,000. So there is some further work to do that. And it was suggested elsewhere this morning that we might want to look at how many dispositions from 111 there might have been to A&E as one dimension driving that. In terms of the work that the A&E Delivery Board is focused upon, I think broadly speaking it breaks down into 3 groups. There's the pre-hospital programmes of work, which many of you will be aware of and participate in, some of the things such as our LCS arrangements for patients. The second phase is around the first 72 hours of care. And I see this as one of the areas where the greatest performance opportunity might be, just thinking in terms of how we might expect to see some improvement above the 88 or 89% or so achievement of the A&E target. And then there's the final third part would be the post-hospital and the discharge planning. And you'll note that we've talked previously quite favourably about our delayed transfers of care performance, our personal health budgets, continuing health care plans, and they all support some of that discharge and flow out of the hospital. So they were the main areas I wanted to draw to your attention in terms of what's happening around the A&E performance board in relation to our constitutional standards. I think again across the rest of the paper, I think it's broadly very positive. In terms of our operating plan supporting activity, the one area I just wanted to highlight was the performance around the outpatient procedures, where there was a change in how the HRGs, or the unbundling of diagnostic imaging, was handled in terms of the operating plans. Some guidance came out after we had submitted our plan, and it's created an artefact in how we're counting that. And we're trying to work together across South West London to fix that particular issue. In terms of clinical quality review groups, there's nothing that I would particularly want to draw to the governing body's attention. There's some good work happening at Kingston Hospital and Chelsea and Westminster. And in terms of the last Integrated Quality Governance Committee, we received the quarterly Safeguarding Adults and Safeguarding Children's report. And I just want to signal to the governing body that I'll be bringing the annual reports for both of those areas to our next governing body. So I won't talk in any great detail here because I'll save that for the next meeting. One last thing which I had a specific request to draw to the governing body's attention was around our performance for personal health budgets. So personal health budgets are an important strategy as part of the long-term plan to increase personalisation and people's control over their health and how health is provided for them. We do particularly well in that regard in the Kingston area, and we exceeded our trajectory requirement for last year. And we are on track to deliver that for this coming year. We particularly have focused on continuing healthcare, personal health budgets in the past, and we want to expand that into learning disabilities, mental health and children's areas as well, so that we more equitably provide that support for people in controlling, to some degree, some of their health provision. But that was a specific request that governing bodies had that drawn to their attention during this month. I'll pause there and say I'm happy to take any questions, sir.
Thank you, Fergus. Comments or questions for Fergus? Yes, Nadine.
Question around the A&E performance. I mean, I think you summed it up very well, which is the concern I think quite a few people have had, is around how we design the emergency flows. The emphasis in the last few years has been very much around developing the UCC, which was flagged up would be a magnet for more patient attending. And I think this is across most of the UK hospitals, is that all are facing similar problem, because in order to achieve the performance standard, more money and finances and resources and experienced staff have been pulled into the UCC, which I think would be the wrong thing to do, because it has led to this situation where more people are attending A&E because they find it easier and convenient, whatever the reasons are. I think the emphasis should change at some point. People realize that it actually is around discharge planning, and unblocking the beds will be much more effective way of achieving the 4-hour standard, because opening up the facility for more and more urgent care centres is really, I don't think would help at all.
So I note it's not the first time you've cautioned us about this as an outcome of developing urgent treatment centres, and I think at the same time I'll balance that with it was a requirement that we put them in place. And so I don't know that I'm necessarily senior enough in policy to determine that was... Yeah. So I think you were wise to point it out, and I think we're experiencing some of the things that you suggested would happen, but it was an imperative that we created the urgent treatment centre solution as part of our urgent and emergency care offer. On the issue around discharge support, I completely agree. I think it's been an area that the CCG has focused a lot on over the last 2 years, and in particular the shift in focus from delayed transfers of care onto stranded and super stranded patients. For those not familiar with that, it's those with a length of stay greater than 6 days or greater than 21 days. We focus a lot within the local system on that. We get the reports on a daily basis, and I'm really pleased to say that we as a CCG are very responsive to requests from the Trust for support around that. And indeed, if you pay note to Neil's report on our finances, you'll see some of the output of that coming through into our financial performance as well, around placement without prejudice and continuing healthcare. So I think it's an important quality measure, but I think we need to also bear in mind the operational and financial impacts as a result of that.
Thank you. Okay, any other comments from board members? Rob, if it's quick, because we're going to start running into time issues.
So London Ambulance Service have a very complex algorithm for their live dispatch. So effectively they have a mechanism by which they will understand where are the right places to take any given patient at any point in time. And a proportion of that is determined by the waiting times for their ambulance crews live on that day at that particular moment in time. All of the accident and emergency departments are also able to see what the activity is inbound to them. So there is a screen that will say you have 2, 4, 6 ambulances. It will give you their estimated time of arrival and a very short overview as to what that presenting complaint is. In terms of turnaround times at Kingston Hospital, I'm really pleased to say they're one of the best in South West London and indeed in London for their turnaround times. So South East Coast Ambulance Service do use Epsom and St Helier, but they also use Kingston Hospital too.
They didn't know, the thing didn't know they could go there.
I think they do liaise with each other to talk about where it is appropriate to take certain patients. As regards the 4-hour standards across Epsom, St Helier and Kingston, they're roughly around about the same. I think Epsom, St Helier are probably a little bit lower in achieving the standards. So all we're doing is just shifting the problem to somewhere else. Very briefly, as regards South West London report, was there anything particularly you wanted to highlight with that?
No, I capture it in my opening or my cover sheet, and it's there for comparison. Just I talk in detail about Kingston. It's there for people who might be interested to see how we compare to others.
Thank you very much, Fergus. Okay, so if we can quite briefly come through, because we've got a substantive item on the agenda still to go through later on. So Finance Committee, summary, Neil?
So for the Finance Committee, we discussed the finance report, which we've included in the governing body papers, and the QUIP performance, which is also included in the main report. So I can go through that as we report the finance position.
Thank you. And do you want to go through the report then?
Yeah, sure, if that's okay. So I was just going to take you to page 136 in the papers, which was just the summary position for the CCG. In month 2, we've got pretty limited information, but we have reported delivering our planned, against our planned year-to-date position and our forecast out-turn position for the year. The financial risks we've reported risks of about 3.1 million. However, we have mitigations to offset those risks. As Fergus mentioned, I think the real pressure we have is in continuing care. There's still a bit of uncertainty, particularly where we've had 16 patients, 16 clients who've been discharged to assess, and that's caused an additional cost pressure in this month. We are still quantifying what the full impact of that is moving forward. So at the moment we're showing a marginal overspend in CHC. We're not extrapolating that into our forecast outturn at the moment. We're trying to make an assessment of where we are during this month. I think the only other thing to just flag is at the moment we're not expecting a pressure on our block contract with Kingston Hospital. However, there is only a 2% tolerance in expenditure terms, and as we've reported in the previous item, there are some activity areas where we're already showing year on year quite significant growth. So we're doing some further work about just quantifying where that pressure might exist. The overall activity shows a big reduction in longer lengths of lengths of stay non-electives, but offsetting a growth in a small growth in the zero length of stay. But we have as yet to do an overview of what that means for the contract, and we have the tolerance across the whole of South West London, not specifically for Kingston. So there may be a sort of marginal risk there, which we're still trying to quantify.
Right, thank you. Comments, questions for Neil around the finance? No? Okay, so we'll just keep an eye on the the possible overperformance there. So thank you. If we can come to the council members' report, Atin.
Thanks, Chair. Won't be very long. Since the last governing body meeting, we've had 2 council members' meetings with good representation at each. At the May meeting, we welcomed Iona Liddington, Director of Public Health, who presented the latest developments in the Connected Kingston project. I won't go into details of that because she presented it already today. Nadine Lane and Philip Cohen, who are our Macmillan social prescribers, gave us an update on the work being done in the cancer side. As mentioned, the service is funded by Macmillan and led by Kingston CCG in conjunction with Kingston Public Health. It's been a really welcomed service. Patients have had a really good experience so far in improving their well-being, and it's also been shown to reduce the need for primary and secondary healthcare. Much of the service was aimed at addressing concerns such as emotional well-being, socialising, physical activity and returning to work, and support with finance and housing issues. We welcomed Dr. Nasrani to inform the members of the proposal to move towards the merger of 6 CCGs in South West London to enable developments with the requirements of NHS, the long-term plan, including the creation of primary care networks and for cost-saving targets across the CCGs. At the June meeting, we welcomed Miss Meena Shankar, who's the Clinical Director for Ops and Gynae at Kingston Hospital. She gave a presentation to members on the developments in gynae services and the outpatient transformation programme. She also presented the new direct access hysteroscopy service that's available and now up and running for GPs in Kingston. Julia Travers, Director of Commissioning, also provided members with an update on the Kingston Health and Care Plan, and as already presented, including a rundown of the Start Well, Live Well and Age Well plan. She also presented details of the draft strategic vision for the future of the Queen Mary's Hospital site in Roehampton. We discussed the current service provisions as well as potential future plans, and further proposals will be shared with the Council of Members as they're developed. And finally, Tonia Michaelides, Managing Director, updated us on the latest developments with the Moving Forward Together programme and the proposed merger of the South West London CCGs. She discussed the drivers and rationale for the formation of one single South West London CCG and the governance arrangements moving forwards, including the role of the Council of Members. Members agreed that retaining local delegation and control would be crucial to our local needs, as well as retaining our local budgets. It was agreed that a small working group would meet to discuss how we would want governance arrangements to look, and this has happened already, and at the next July meeting there's going to be a workshop to discuss this further. Thanks.
Thank you, Atin. Any comments for Atin? Okay, Tonya, do you want to take us through moving forward together?
Thank you. Nice segue in from Atin's report, isn't it? And so the paper in front of us today is an update on the Moving Forward Together programme. For those of you who don't know what the Moving Forward Together programme is, it is a programme that supports the progress towards merger of the 6 South West London CCGs into a single CCG. So the paper in front of you is really 2 parts. It gives you an update on the work that we're doing at a South West London level to progress this piece of work, and then we have a section on play. So if I take it in 2 parts, I know Naz and Sarah and others will want to comment as well. So to begin, I think it's really important to remember that we're not starting this from scratch, that we've been on this journey for a while now. For over a year, we've been working together as 6 CCGs, and we are committed to ensuring that we have a successful place-based local system supported by its scale when necessary. But as we started to work together, there have been some new policies, initiatives that have come online that have impacted on how we currently operate. So we have the development of primary care networks. I'm not going to dwell on that today because I know through the Primary Care Committee and Jim that we've discussed that, but I just want to acknowledge that we now have the primary care networks in Kingston established. We know who they are. I'll be working with them over the coming months to get them up and running. We've just heard from Julia about the health and care plan. That really is a start of strengthening our local health and care partnerships. We do want to move away from a commissioner-provider split and actually more focus on the person rather than the organisations. And actually, every time I say this, and everyone says that's the right thing to do. I think we know that we need to move into a much more collaborative and transformational approach. And we do know that the expectation in the NHS long-term plan is that we make 20% reduction in management costs. Each CCG is asked to make that reduction so we can reinvest that money into frontline services to deliver the ambition of the long-term plan. So those are some of the initiatives that are also driving our thinking, but generally it's that bit for me about that. Actually, we've been on this journey for a while now. This is evolution, not revolution, and we've got a real opportunity to really strengthen those strong working arrangements that we have in place. So we have created the Moving Forward Together programme that's led by GP clinical chairs in partnership with the South West London senior management team. We meet fortnightly to share updates, how the programme's moving on, and also share reflections from our membership particularly, but other partners around their views on the Moving Forward Together programme. It is supported by a programme structure with 5 clear work streams. It ensures that pace-based development is being led locally, and it also builds on the engagement we've already undertaken. So if I just move on to the case for change. The case for change is still being iterated as we progress the programme and we have further discussions. We can develop our case for change, but we do believe it's a strong case for change. And the 6 points there, as I said, it's evolution, not revolution. This gives an opportunity to invest in primary care networks. We have the building blocks, which are the building blocks to improve services. We have an opportunity to not only retain, but also enhance local teams to support practices through these changes and their new responsibilities. We have the NHS long-term plan that Sarah mentioned at the beginning of the meeting, and that does focus on collaboration rather than competition. The end of the purchase should provide a split and more resources to invest in frontline services, and we can reduce red tape at local level and free up that resource. We've absolutely committed, and I'm very pleased to say the leadership in Kingston has indicated they would like to seek 100% of the allocation back to place for the services that we provide. But we recognise at least 80% of that care would be planned and delivered locally with strong clinical leadership. But we also know that some of our services are better planned and managed on a wider footprint, and we're working with our other colleagues across South West London to determine that. And we do want to take control of our future. We've got an opportunity really to test bed some of these new ways of working, not just for South West London, but share our thinking with our colleagues in London and nationally. So we've got a great opportunity to be at the front foot for this. So if we go back to a bit about evolution, not revolution, one of the real benefits I think we have of working at scale over the last year or so is the level of transformation money that we've been able to attract into South West London Health and Care Partnership that we would not have been able to attract if we'd bid for that money on an individual CCG or borough basis. So we have been able to bring into South West London £1.85 million for children and young people's mental health to create enhanced mental health support teams. That was wave 1 of the Green Paper Trailblazer funding. We have put a bid in for wave 2 for South West London, and hopefully we'll hear if we've been successful shortly. We also managed to secure £1.6 million to help new and expectant mums in South West London to have access to specialist mental health teams. 2 or 3 years ago, we did not have a specialist perinatal mental health service in South West London. We now have a very successful one. And we have got £9.9 million into South West London to support our digital transformation programme. So that's been one real positive about working for scale. As I say, we would never have been able to either get that money or at that level if we bid for that on a CCG or borough basis. We already have improved some of our functions by consolidation. We have a very successful communication and engagements functions across South West London that is embedded in local CCGs but also works at scale across South West London. And we have been able to remove some of the postcode lottery we have for care in South West London through having an ECI-aligned decision-making process. So that's some of the examples of why working at scale is good and a good thing, and absolutely drives through change that we wouldn't be able to do on an individual borough basis. I've got next couple of slides on GP investment, and given time, I'm not going to go through those in detail. The next slide I'm going to draw your attention to for this part of the presentation is actually the second one of the cut red tape and duplication to invest in frontline services. Because I think this is really interesting, and when I read it the first time, it did make me think. So on that page, it's the continued page where it talks about the potential merger of our CCGs would also free up resources for frontline services. It's the second bullet point that really caught my eye. So we currently have 6 governing bodies, which we know about. We actually have 18 associated statutory committees for them 6 bodies. We have 6 annual accounts and auditors. We have 6 assurance processes from NHS regulators. This in itself takes considerable clinical and managerial time to service. And if we moved to just one CCG governing body, we would save at least £1.6 million because we wouldn't have to do everything 6 times. So that takes a lot of time and effort. But we also, this is something I'm very passionate about, I've worked in Kingston for a number of years now, and we've done really well to attract talent, but we haven't been able to give those people the opportunity to progress because we're a small organisation. So if people want to progress their career, they usually have to leave Kingston CCG because we just don't have the structures that are large enough to be able to have demonstrate progression for people. So becoming together with one CCG, we will be able to have people that we will be able to retain that talent in South West London, opportunity to work in Kingston, but also when they want to progress with their career, they can stay in South West London and work in a different place. So that's another really good reason. And the next section, section 5, starts to describe how we will seek delegation and the level of delegation we will seek. As I say, I'm very pleased to say that the leaders in Kingston do want us to seek full delegation of the commissioning resource for the borough of Kingston. And our vision for South West London is that each place or borough will bring together health and care leaders in the local system that would have real ownership and accountability on that budget. So I think we have a real opportunity to enhance that local oversight and leadership on the resource that we use to fund healthcare in Kingston. And then the last slide is just about taking control of our future. If we were to merge, we would want to make sure we designed our own model for the way we work, a way that works for our GPs and our partners in each borough. We would like to progress quickly to ensure that we can influence national thinking and deliver our South West London model. I was just going to end that part of the presentation on the South West London approach before I go into place. But I look to Naz and Sarah if they want to add anything else to that part of the presentation.
Tim.
Is it okay to ask the question at this point? So if we in Kingston are going to retain some element of delegation and budget, but we don't have roles such as finance officer and operating officers, are we able to still perform those functions statutorily? And also, if we are going to have those roles, can we still make the savings required?
Oh, is that on? That's it. So you won't have exactly what you've got now, but you will have some of those roles, and they'll be supporting you in delivering what you need to deliver. So the statutory functions will sit at South West London level, so you only need one set of counts, but you will still have a finance person where you've got budgets to help you to manage the budgets, and they'll still be reporting up to South West London to make sure that we fill all our statutory responsibilities. So you will still have people, and actually we're looking at the functions now and the staffing, because what we want to do is to still retain as much of staffing locally as we possibly can, and particularly around general practice and supporting transforming primary care. And in fact, we might want to increase that rather than decrease it. So we're trying to make as much of the savings as we can through the kind of more bureaucratic back office type roles as we can, and actually just by reducing the number of governing bodies that we have. So that's the plan. We cannot promise that there'll be no sort of staff movements at all, because obviously there may be some, but we want to minimise that as much as possible. The other thing is that we would expect people to work across South West London, so even if they were, which they do now, doing a role that works on behalf of South West London, they can still be based locally and be working with local teams. So I would hope that you will still have the level of support that you need at local level in order to deliver it. The statutory function sits at the South West London level, which means those back office statutory functions only need to be delivered once, but there will still be roles that will be required locally, and that's the piece that Tonya's working on at the moment to kind of come up with a structure that meets the requirement for the local place. Did you want to say anything on your local place structure?
Before we, I think, David, do you want to come in?
So yes, absolutely. We're just finalising the structure for Kingston Richmond's LDU. So we are proposing to retain the LDU because actually it has really helped us build our capability capacity locally, and actually because we have so much synergy between the two boroughs in some of our transformation programmes, it absolutely makes sense. So we're just finalising that structure. You'll be mindful that it is still in draft, so it's quite difficult to share, but I can absolutely give you assurance that as it looks today, it would give absolutely the level of support that we have now. But slightly different roles, because we can improve on what we have now, but we have got, I think, the right level of support to carry on the work we need to do in Kingston.
Okay, David, do you want to come in?
So thank you, Dave. Can I just add to that? So I was going to try and give an example around the finance, because I think the finance is a really good one. So currently what you have is you have finance teams who part of their job is to fill in what they call FIMS, which is the what they have to do for the regulators, because they're a statutory body on a monthly basis. They have to produce monthly accounts, they have to produce annual accounts, we have to work with the auditors, All of that, or a lot of that, would happen at South West London level only once. What they would be doing locally is looking at the budgets that you have, making sure that you're looking at whether or not you're getting best value for what you're doing, being efficient, trying to make sure that you have the information that you need in order to make recommendations about what you want to do locally in order to make best use of public resources. All of that will stay. It's just that that formal bit around doing all of the reporting and the annual account and all of that, that will disappear from the local, and that will only be done once across South West London. And by doing that, you actually achieve quite a lot of savings just in not having to do six lots of something. That's quite a good example of, so you'd still have finance people and they'd still be working on things like, if you change this pathway, what would that do to the money? How do you best use the money? That kind of stuff. What they won't be doing is all of the reporting upwards, talking to the auditors, all the stuff that will be done at South West London level. They still need to account for the money and the actions.
So any other comments or questions for Tonya? I mean, this is a process we're currently exploring with our stakeholders, our partners, and especially our councillor members. So we are trying to put some realism on it, as we said at the councillor members before, is to try and work through a couple of scenarios to give some confidence in what can be delivered at a place level, because an awful lot of the discussion was just making sure that we've got the ability to still plan and transform at a local level.
So just on David's issue around place, the only reason we call it that is that because that's the national terminology. My view is we don't need to call it that. I mean, when we talk about place, we mean borough in South West London. So when we talk about Croydon, they talk about one Croydon. That's what they talk about, one Croydon. Sutton is Sutton Health and Care. Kingston Coordinated Care. You know, we can talk about whatever we can call it whatever we like locally. I don't think we should get bogged down. I think when we are trying to describe this to the regulators and what we're doing, we use that terminology because that's recognised as the terminology, and actually the local authorities kind of recognise the terminology of place. But I think for local people, you know, it'll be whatever you want to call it, and if that be Kingston Coordinated Care or Kingston whatever, then that's fine.
I'll just come back briefly because I think that's a very nice way of telling me that I've made the point many, many times previously and I don't need to keep on making it. And I take that point. But it still is the case that I heard someone from the council, as it happens, a councillor, talking disparagingly about the use of this thing called place, which was being introduced in the NHS. And my concern is that that way of talking will become common currency, and that will get in the way of actually getting the value from these changes and explaining them in local terms in which people can understand. And the sooner we agree precisely what we're going to call it in the Kingston. I like NHS Kingston. I used to think that was a very good way of describing ourselves. I know that's not possible. But a phrase which will identify it as being Kingston's, the sooner the better. The other one, which I didn't mention, by the way, is, of course, there's an overarching issue in relation to staff for Kingston and Richmond, and that has the potential for a bit of complexity which will be hard to initially to explain, and it needs to be sorted in the next 6 months, really as a matter of urgency.
Okay, thank you, David. I do know that we are going to be bringing this back in. Sorry?
I was doing it in two parts. So, sorry, I say, and I actually agree with everything what everyone said, and functionally, I did present this very same presentation to Kingston councillors yesterday evening. They didn't mention the use of the term place to me then, but I absolutely accept, and I think we will not be using that term as we move forward. Yeah, so I think we just anyway. So I think we the other thing I would want to say, we are trying to do two things, and I absolutely recognise David in the complexity, because we are trying to establish the single CCG and also establish our integrated care partnership, which are two connected but different things, and that's where the complexity comes in. But I absolutely know that we've got the foundation blocks for our integrated care partnership in Kingston, because we have got the Kingston Coordinated Care Partnership Board, which starts to have the right members. It needs to do more work, and I can talk about that in a minute. But I am conscious in time, so I know members will have seen some of these slides already, so I wasn't going to go through them in detail. The slides that we're going to draw your attention to is how our approach for developing place in Kingston. So we are engaging with stakeholders across the borough. I've been talking to patients. I've also been to council meeting last night. We're going to Health and Wellbeing Board. If there is any other group you think would be interested in hearing this, I'm happy to come and talk to them, or other colleagues are happy to come and talk to them. So we are engaging with stakeholders. I'm pleased to say on the whole, stakeholders are really engaged in this piece of work, but recognising that we need the granularity, the detail, and as we start working through what does this governance mean, and how can we do things differently, I think that's the test for us. So what we're proposing in Kingston is to establish the place committee in shadow from September, October. So we've got 6 months to work in seminar workshop form to work through some of the issues that we think we might face as we go live into next financial year. So one of the things I'm very keen that we do through that seminar approach is actually develop the terms of reference. I've sat on too many new established committees where we spent the first 2 meetings talking about terms of reference. We can do that. We've got 6 months to sort that kind of issue out and have it in place so we're up and running from the 1st of April. So we are building on the work and engagement undertaken as Development and Health and Care Plan and the work of the leadership group in Kingston that's been established for a number of years. But we do recognise that this is not going to be something that can be done quickly, and also I don't think it could be something that can be forced onto people. So there isn't going to be a point in time when we will say from the 1st of April or this date, everyone will have to have a combined budget or a pooled budget, because we know that that won't work, and actually we will lose the engagement and the commitment that we have in place now. So we're doing a piece of work now to get us up and running for the shadow from September, to identify the work that needs to be done and the achievements that need to be made in order to move from phase to phase. We're using the King's Fund 10 principles to delivering systems of care to help us form our thinking. That's a really good checklist. I find it an interesting checklist. We're using a timeline for the development place, working backwards from April 2021. If you remember in the long-term plan, it says that England will be covered, completely covered by integrated care systems by 2021. So if you work back, the Kingston Integrated Care Partnership as part of the integrated care system for South West London, what do we need to do? So we're talking about short, medium and long term up to 2021. I'm really pleased when I talk to the leaders, the first thing they say to me, we think we can do this quicker. So when I started to describe the activities in the different time frames, they said, yeah, that's great, Tonya, but actually we think we can do this quicker. So that bit about challenging ourselves to move forward at a safe but steady pace is really important. So we are very much in the discussion, debate, conversation phrase at the moment. So going to the members, council members, but other groups about actually how does this place work. So we've got one-to-one conversations. What's come through very clearly in the last couple of weeks from the governing body and others as well, that we need to make sure the clinical leadership is very strong in our model and it's not in an advisory role. So how do we make that, and that's something that's it's an open-ended question. Anyone's got any answers, please let me know. How do we make sure that we have the strength of clinical voice in its widest sense, not just around the CCG, but with our partners that supports the place? And we are using some of our existing structures to take forward this work, such as we've just established the finance and performance group that does straddle Kingston and Richmond to work together on how do we have a system architecture and a shared understanding of our risks around financial risk particularly, but our transformational risks as well. So my last slide is so people are aware of the timeline. So this is the timeline. We've finished June, so we've done all the activity up to June. We're now in the 2 blue circles between June and September. So function structures agreed internally, and we're just finalising that with Sarah at the moment. And then we are also looking at the application of the paperwork to be able to take to members in September. We then will go to membership in September for their support. The merge application will be submitted to regulators. The regulators are looking at their own process at the moment, so I'm sure they will want to do that quite speedily. We will then launch our staff consultation October and November with an aim to launch the one CCG for South West London in April 2020. That's my whiz through. As I say, this won't be the last and only time we will talk about this. I know through our formal structures, but also through conversations, we will have more opportunity to contribute and develop our thinking. But I'm happy to take any further questions.
Okay, thank you. Any other questions from board members? Because I think quite a lot of us already seen this sort of pack and the development and been engaged in this process. Sarah.
I just thought I'd mention, just because I mentioned it at Richmond, we've just got a set of FAQs for the membership, because I know that the membership are asking lots of questions. What we will do is we'll finalise those with the chairs this week and get those out to all members. But if members of the governing body are hearing questions from the membership that aren't included on that, or they think we could include, we will keep that up to date. So please let us know, and we will try and answer those questions and keep them up to date on an FAQ. And we'll make that live for people.
Great. Thank you. Right. Is there any other comments or questions? Neil, do you want to take us through the estates?
Yeah, sure. So this estates update follows some work we've been doing over the last couple of months. The previous estate strategies were updated in 2017. In March, all of the South West London CCGs held workshops to start to generate the revised estate strategies with local partners, purely so that we can actually get more on the front foot for potential capital bids as and when funding cycles arise. One of the things we've done following the workshop is we've now established a local estates forum based on the model that was already existing in Richmond. So that has some of our primary care support staff, plus representatives from Kingston Hospital, South West London St George's, and for the Kingston group, Liz from Healthwatch is also a member. We've established that group and we've met once, and that is aimed to feed up into the leadership structure that we have within the borough. The strategy items we've been working on are to update the local database where we've got gaps, particularly in the building condition and usage, to try and model how we're expecting the population growth of the borough to have an impact on our provision of accommodation. There's anticipated quite significant growth in the population in the centre of Kingston and also in the Chessington area as well. So we've been trying to model how that might impact in the future on the practice provision. We've also been trying to model through the transformation impact. So the extra requirement for staff to support primary care networks, how some of the digital initiatives might have impact on the number of consultations that are actually held in premises, and also how the integration of community mental health teams might have a big impact. We've also discussed in the group how we may want to look at integrating primary care infrastructure support, such as the facilities management that Kingston Hospital, South West London St George's, and also the local authority has. There are opportunities to try and integrate more of that provision. We've also looked at some of the providers' aspiration to share some of the back office and seeing whether or not there's opportunities to relocate some of that shared back office in other accommodation, not on the acute side. So that is one of the initiatives we've been looking at, and also using the forum to liaise more effectively with NHS property services and community health partnerships. So we are working through those strategic items. The issues that have come up as part of the workshop, I've listed there. I think the main ones to flag as important issues, the Hawks Road Clinic will be subject to a redevelopment because of the whole of the Cambridge estate is being redeveloped as part of a programme with the local authority. We also have the issue of the primary care offices in Ewell Road. There is a potential to dispose of that asset. We also have an aspiration to move the 25 beds that are currently at Teddington Memorial back to Kingston on some footprint. And for Gosbury Hill, I must apologise in my phrasing of the bullet point. We've recognised in the group that the building condition is very poor. We think it requires a re-provision rather than just an upgrade. But the Gosbury Hill appears to be one of those properties which we must need to make sure the strategy addresses. And the other thing just to highlight is there's still quite a significant cost for void space that we have in the Manor Drive clinic as well. So as I say, we've captured these issues in various forums, and we are developing an estate strategy. The intention is to try and bring that back to the board at some time later in the year to try and address these issues. The other issues that we've bullet pointed are more just technical, maintaining the estate's strategy. There are a couple of buildings that we just need to confirm with NHS PS disposal of, so we can actually avoid the costs. We hope to bring this back to the board once we've developed the strategy a bit further.
That's been really helpful because it's good to know where we are as regards the estates, because we do need to make sure it is all joined up right across the system. So thank you. Any comments or questions for the estates? No. Rob, if it's quick.
A quick thank you.
That's great. Thank you. And we look forward to getting the estate strategy. Thanks, Neil. For information, you've got the papers on board assurance, the South West London Audit Committees in common, summary minutes, reference documents, that's the glossary of terms. And the next meeting is on the 3rd of September, and I'm presuming there's no further questions from members of the public. So if I can close the meeting, and apologies for the delay, so it's 5:14. If we can just take a couple of minutes comfort break and then head through to the Peyton room for part 2, please. Thanks.